All right, so welcome everybody. My name is Lawrence Benson III, he, him, his. I'm with the Corporation for Supportive Housing, and we're a national nonprofit and been doing work over the past 30 years in housing, supportive housing specifically. I will also introduce or welcome Maya to come off and introduce herself.
Yeah, sure. Hi, everyone. Thank you for being here. My name is Maya Saxena. I use she, her pronouns. I am a senior program manager on our CSH National Consulting team. I am based in Atlanta, Georgia, where it is super hot and muggy, but I will take that over cold any day of the week.
So you're not coming to Boston anytime soon.
Not in the
Uh,
winter. Not in the winter.
I'm also located in Massachusetts, in Boston, and I also work on the national consulting team with Maya as a senior program manager. So before we go in, please, I encourage everybody in the chat, we wanted you all to put your name, your intro as well, where you work, your state, and one thing that you're looking forward to this summer. I know with this series, there are four different trainings that we'll be doing in this training group together. So want us to become familiar with each other. Before we go anywhere further, I just want to tell you why this series exists. We built this for the people doing the work, the community health workers, the navigators, the supervisors, the care coordinator leads, the folks connecting patients to what they need every single day. Leadership, you're working here as well, but this is specifically for those direct service staff who are often left out of these meetings. But we're glad you're here. I want to be honest about how we designed this. This content was built from the ground level first, with practical tools, real workflows, and things that you can put your hands on this week. Um, this is a small group training, and it's not a webinar where you mute yourself and you check your mail and you don't pay attention. We're going to have the chat. We'll use polls in the other sessions. And at a few points, we're going to ask you to come off mute and teach each other as well. Um, Only three ground rules that we have. Cameras are optional. There's no pressure if you don't want to be on camera, but it is something that we do encourage. Please put any questions in the chat at any time. We're constantly looking at it. So that's the other one. And number three, never hold anything in that you think may be an obscure question. It's probably the same question someone else has. And I want to make sure that everybody has that full experience. You just never know when you have that important question. It's the same thing somebody else is thinking, and it helps educate all of us. Any other ground rules that we want to institute before we move forward? All right. So this is session 1 of 4, Building Effective Community Health Worker or CHW programs. And over this next hour or so, we're going to just talk about what a quality community health worker program actually looks like and how to build one that lasts, past the pilots, past the grants, and past that awkward first year that we have where we're hitting our heads against the wall. And so we'll go to the next slide, please. So all right, so this is mapping the whole series that we have. Today, again, is session 1 design. What does quality CHW programs actually look like? So the roles, the models, the structure, funding, the foundation of everything. The session 2, which is tomorrow, is community needs assessment. So how do you actually know what our community actually needs? Not what we assume, not what the grant said, but what the community tells us and how you can, be within compliance and exercise and help come up with a strategic program that benefits everybody, specifically the community. Session 3 is connection. So building a referral ecosystem, asset mapping, partnership, how to do warm handoffs that actually land, because screening without connection, erodes trust. And we're talking about being honest here. And session 4 is data, where we look at dashboards, potentially quality improvement. How do we know what we're doing is actually working? How do we prove it to leadership, to funders, to HRSA? One design principle runs underneath all 4 sessions, and I want to name this up front. we're trying to help you all find your connection points, the places where your community health workers, the navigators, the clinical team, where they overlap. So you don't stop duplicating efforts, you just enhance it. Because duplication efforts doesn't just waste resources. It also sends our patients into circles, or your clients or tenants into circles, and they're like, I don't know who to contact for what. And so what we want to do is try and map out clarity with the program as well, especially for programs if you have three different positions, what we'll talk about in the next coming slides, that look very similar but are very distinct and different. Every time we meet, we'll leave with one concrete action to move forward. That's fine. And so today we're going to start with the foundation. So here, what matters on this slide? CHW workforce is growing and the evidence is catching up. And we know that if you didn't know about the CHW program and why it's so important, you wouldn't be on this call today. Before we get into the definitions, I want to hand you the business case because somebody at your health center is going to ask. Your CFO is going to ask, your board is going to ask, and I want to walk you through that answer. The first number, okay, you see that on here. $2.47 back for every $1 invested in a CHW program. That right there is coming from the Penn impact model. And here's, how that holds up. It was a randomized controlled trial published in Health Affairs, not a pilot story, not a testimonial. It was the strongest kind of evidence medicine that we know, and it became evidence-based. Fewer days in the hospital. One of the most things that came out of it was having community health workers lower the amount of days that people were in the hospital. That second number, 65%, the reduction in hospital days among the high-risk patients served by trained CHW. The third one, 29 out of 48 states with Medicaid CHW service coverage pathways. That is one of the biggest things that has always been a hindrance for working as a community health worker is how do you pay for it outside of a grant? And there are states now, Massachusetts is one where I'm staying. There are a couple others that, as we noted, that are really getting behind this effort and seeing the quality of that. That came about with a lot of advocacy, but a lot of research that showed the effectiveness of community health workers and how following certain templates and workflows are actually very effective in delivering community health worker services. I'll mention really quickly, some of those waivers. One of them is the 1115 Medicaid waiver. Not something to know now, but just something if you want to Google and see if your own state has one, that's something that you can do today as well. This is not in there, but I will ask if please put it in chat if your state has a community health worker waiver, or if you're being paid, if this community health worker is being paid outside of any other funding outside of a grant. If you can put it in chat, that'd be great for us to know. Next slide, please. Our learning objectives. Okay, so what we're going to do is ask for you all to walk away with today. It's just being able to define the core competencies and roles of community health workers within a health center setting. Identify at least these three evidence-based CHW program models that we're going to show you and how they're applicable to your health center and serving homeless individuals. We'll describe the strategies for recruiting, training, supervising, and sustaining community health workers with attention to community alignment and patient engagement, and articulate the connection between community health worker integration, improved screening, referral, and follow-up for health-related needs, including housing as life-saving prevention and responsive services. These are the core objectives, and we're going to build on that every day. All right, Maya, I think it's over to you.
Yeah, thank you. And again, welcome everyone. Thanks for being here. So I'm going to really quickly go through our agenda. We've done some welcoming, we've done some framing. We'll spend a couple of minutes on kind of just the general landscape of CHW land, talking about roles, competencies, and evidence. We'll then talk a little bit about program design, so taking something from ideation and conception all the way to actually being feasible to operate. We do have a workbook that goes along with these sessions. That'll be something that will circulate to you all after the session. There is a short program readiness assessment in there. So something that we'll mention later in this session, but something to look out for after today. And then we'll move into a little bit of wrap up, some takeaways, and some action planning. Like Lauren said, we hope that this will be, conversational. We realized that this was originally a 90-minute session today, but thought, it's 4 o'clock for a lot of folks here. Why don't we try to make it an hour? And so, in effort to do so, we'll send that workbook on afterwards, and have some quote unquote work for you all to do in between the sessions. Okay, so we wanted to start the content off today by clarifying roles, which can prevent CHW program confusion or CHW program failure. And we know that in smaller health centers, these three distinct roles are often super blurry. People are doing multiple responsibilities out of each of these buckets. So to break them apart, first we've got the community health worker who is acting as the frontline public health worker with close connections to the local community. And their scope of work includes outreach, the non-medical factors of health screenings, health coaching, system navigation, patient support where it falls appropriately within the role, and they work upstream of clinical care and alongside clinical care. The second distinct role is a specialist or a peer support specialist, who is an individual with direct patient experience in behavioral health or recovery. Their scope of work includes peer support, recovery coaching, engagement and treatment, and peer specialists are often certified through state behavioral health systems. These two roles are not interchangeable. The third distinct role is that of a patient navigator, and this person's scope of work is focused on guiding patients through that clinical care system. So things like appointment scheduling, insurance navigation, warm handoffs in between different team members. And typically they have a more narrow community reach than community health workers. Role clarity is important to avoid duplicative services, and to treat patients with integrity and respect. As Lawrence said, sometimes patients can feel like they're circling around between a bunch of different folks. And that's one of the things that we want to prevent is that feeling of being passed around. When things get blurry, for example, maybe you have community health workers who are scheduling appointments, or you have navigators who are doing food resource referrals. And then maybe some of your peer specialists end up doing clinical follow-ups. And the roles start to overlap and things start to become a little messy. A clear delineation of responsibility not only makes patients feel more heard and more respected, more valued and seen, but it also eases the workload of all of our staff, knowing that we have our lanes and knowing that we know how to refer to each of these three distinct roles when something doesn't fall within our lane. And Lawrence, I think it's back to you for a minute.
Yeah, thank you. So we were given those three roles and then know that as we talked about it, it can be confusing. How do you separate the two? Well, there's a framework for that that keeps them separate on paper and in daily practice as well. It's called the C3 project. I don't know if anybody else has heard of it. If you have, shout it out in the chat. It's the National Community Health Worker Core Consensus Project. So you all have heard of it. Great. And that word consensus is what you want to hold on to. It was a multi-year national process where community health worker associations and researchers came together and agreed on the core scope of this profession. It was first published back in 2016 and then later updated most recently in 2022. Just a side note, one of the big things around community health workers is how effective it was. They were in COVID and helping with the epidemic, whether it was community health workers that did field epidemiology or contact tracing, they were very important during that era. So what came out of it was these 10 core roles or 11 core skills. They're on the slide right now, what we're talking about. On this slide, you see outreach, education, informal counseling, social support, care coordination, system navigation, health promotion, the full landscape of what this workforce actually does. But why does it matter? When a health center writes a community health worker job description without C3, here's what happens. And, I've watched it happen myself. Duties pile on one at a time. a little scheduling here, a little transportation support here, food resources, the clinical follow-up, until one role has carried into 3 jobs and then 3 jobs into 10 jobs, and no supervisor on earth can support you doing all of those jobs. So with C3, you can do something very different. You can say, this community health worker does these 4 roles at 80% of their effort, and these 2 skills at 10% level. There's a design, and that's what we're doing. We're making sure that this is designed with the most impactful outcome possible. You can show a funder exactly what they're buying. That's a fundable design. It's maps to reimbursable activities as well. So when we talk about, when I said Medicaid 1115 waiver, you can map that to these core competencies and what someone is actually doing from that. And what that supervisor also qualities that they need to have and look out for as well. So how to use it, there's 3 moves. The first one is to make, to see through your spine of your community health worker job descriptions before you post a position, not after. The second one is map every role and a skill to a real workflow or a real training module. Um, it's very cumbersome. And I'm also, and I don't think I said this earlier, but I'm also a certified community health worker here in the state of Massachusetts. And there's nothing more cumbersome than coming into a job and not knowing in a list of all the skills that I should have prior to even starting, and then having to pick up 5 or 6 of them at one time when I'm dealing with diabetes or high blood pressure patients or homeless patients as well with complex issues. That's one of the things that we want to try and think about ahead of time. Yes, they will be available. So yeah, right after that. And then one of the other things that I would say, so number 2 is to map the role. Number 1 is to make sure you have the description spine. Number 2 is to map every role. And number 3 is revisit it every year. As a supervisor and as a program director, role shift, you want to annually review this, depending on who the population is, what they're serving, where for HRSA and anything that's HIV related, for any of those new trends that you're seeing, you want to make sure that you're setting yourself up for that final year for success. Let's go to the next slide. So I gave you the headline number earlier. Now let's give you the stack, because when you take this to your leadership, you want more than one study in your pocket. First, the systemic review. The Association of State and Territorial Health Officials review the CHW programs across some of those areas I said: diabetes, asthma, hypertension, and maternal health. And the return on that investment range from 3 to 1 to 15 to 1. So the range is intensified by the amount of work that you all put into when you set up your program and how many people are actually touched by your community health workers. The range, it depends on the intensity on the community served, but the floor is 3 to 1. So the second one is the readmission. This one is one that I really hone on, because a lot of people, especially if you're in a healthcare arena and you're working at a health center, need to understand that as one of the biggest things that we're trying to prevent is hospitalization. Lowering those hospitalization days, lowering the need for going into the hospital are things that CHWs are really affected by. Why? Communication, being a middleman, being able to run back and forth, but also support those needs that the doctor just can't handle, or whoever the specialist just can't handle. That's one of the great things about the community health workers. Also, being a little bit more mobile than some of the other clinical team is a huge portion of how we're reducing readmission just by the duties and the flexibility of the community health workers alone. This third number matters most to our work together: being prepared. If you don't know it, prepare is what the most widely used social risk screening tool in health centers, built by the National Association for Community Health Centers. Patients screened with prepare averages 7 positive non-medical needs, 7 out of 22 of the tools asked about. So some of those things are housing, food, transportation, and they are ordered. So we're here to so we hear the questions that set up the rest of the hour. Your screening tool just found 7 needs in one patient. Who on your care team is actually built to act on them? Not the provider, not with their 15 minutes in the panel that they have, not the front desk because they're answering the phones, not the nurse case manager, even though they're a case manager, they're really looking at the medicine if that's in your department. Patient navigators, that's not really where they fit into this with the role clarity. This is a CHW role. This is the only one on the care team designed to act on all 7 of those needs. And I always refer back to the Maslow hierarchy of basic needs. That's the needs that are foundational to everyone. And one of those most important one is housing as well. I know housing has not been systematically incorporated into a lot of the healthcare spaces because there's been silo, but we're hoping that with this training series, we'll be able to bridge that gap together. Next slide. So we're building this off of 3 evidence-based community health worker program models. The model 1 is impact from Penn Central Center for CHW Research. This is structured, standardized 6-month intervention for lower income patients managing multiple chronic conditions. It is the only CHW model with multiple randomized control trials behind it. That 42, that 2.47 amount that you see there is the ROI I gave you earlier. This model, it ran in more than 20 health systems across the country. The best win, chronic disease management, is our priority: diabetes, hypertension. The patient is your, sorry, the patient your clinical care team worries about at night. That's where all of this went into. This is how we came up with the best model for chronic disease management and how to prioritize them. The second model is the Pathways Community Hub, developed by the Reading in Ohio, validated through RHRQ. Here's the elegant part about this one. Risk is broken into more than 20 standard pathways: a housing pathway, a food health pathway, a prenatal pathway. Each pathway has a defined start and defined finish, and CHWs are paid per completed pathways, not per contact, but per completion. That structure makes it billing compatible, high data rich by design. Every pathway is a discrete deliverable you can put in front of a payer. Best win when you need a reimbursable model tied to closed loop referral. We talk about that, think about Medicaid. That's what we're talking about with that. Thank you, Maya, for answering that. And then our third model is the promoters model, represented nationally by our partners at MHP. The design principle here is community embeddedness. CHWs who come from the same linguistic and cultural community as the patients that they serve. Not similar, but the same. And it's an essential and especially strong fit for migrant communities, the agricultural communities, multilingual communities. This concept around Model 3 can also be incorporated in some of the other models as well. When hiring your staff, you want to make sure that they can navigate the community just as effectively as the patient. There's a lot that's lost when they aren't able to navigate and they need another CHW patient navigator to get them around some of the services as well and how to connect to different places. Now, here's the teaching point, and please hear this. None of these is the right one. The question is never which model is best. The question is which patient community dominates my panel. Match the model to the community, not the other way around. And I don't want to do this graph pieces of all 3 of them together. A little impact here, a few pathways there, some promoters, principles on top. I understand the temptation, they all have good parts, but that's exactly how you get role ambiguity. And you have this place of no defined roles, especially if you're incorporating patient navigators, peer navigators into the roles as well. So that brings me into a question to you. We've been talking about the models and abstract. Where is your program today? And what does that look like? We're going to launch a poll right now where you'll be able to let us know that information. And we know this is not trivial. We know that the answers here also help us dictate how we go deeper in the next couple of sessions as well. So please, if, as honest as you can be, that'd be very helpful with this.
Yeah, I'm seeing a lot of pilot or grant funded programs in place.
Mm, which is good to know because
Mhm.
the biggest thing is sustainability, sustaining your programs. I also invite anybody if they wanted to, for a second, come up and talk about their program for a second. I invite you to do that as well while we're finishing the poll. Don't be shy.
Maybe some of the folks who are running those pilots trying to think about what comes next.
Or anybody that's on camera, Debbie or Sylvia.
I can start. We're a pilot. We're fairly new to this. We use them in a couple ways. First, we do the SDOH assessment, and those referrals are sent to the CHW to connect to resources. Second, we have a mobile unit that we've had for a little while, but we're still trying to find our footing with it. The CHW will go out into that community, try to do some education and awareness so that we do get appointments when we take the mobile unit out there. So we kind of have a couple different programs that we're using her as needed. It's not as structured as I would want it to be yet.
What a great place to start. Anybody else? Oh, we see in the chat, I was awarded an SDOH Accelerator for a grant for 4 years ago to create a plan to create and implement a team of community health workers to be employed by my health department. Our plan is great. We haven't been able to secure funding yet. Understood. Thank you for sharing that, Carrie. Anybody else? We got most of the polls in, and it looks like majority of us are in that pilot grant funded program in place. Has anybody still been on grant funding and but it's not a pilot? Like how many of you all are not in the pilot phase, but you're all grant funded and have been doing this for a year or so outside of that initial pilot year? Well, I know that's sometimes, so that first year after pilot, it can be the first year is always a nut because you're trying to figure out where you fit in, where to develop the workflow, who is going to integrate with where and how and those things. So it is always that, and we are thankful for grants to build that capacity up so that you all can finalize how this program is going to look. And then, but I will always say, if you're established, thank you, Rochelle. So y'all are established program as well. Sustainability should be on your forethought now for those folks who are in this pilot and grant funded phase. We know that they're in changing times, there are new directions, there are funding that streams that are available. That's why we mentioned the Medicaid stream as a potential for 29 of the states, depending on where you are, where you could potentially be able to be reimbursed for the community health worker services that you all have. All right, next slide. All right, so this is the operations part of the program and how it's structured. And I apologize if you hear my cat in here being annoying. So there are four structural components. These are what have to be in place before, some of them before you even hire your first community health worker, not after, because it can really lead to you, A, not supporting your community health worker effectively, and B, scrambling to try and pick up these pieces that should be in place already. So number one is the staffing and supervision. So we just recommend one supervisor per 5 to 8 community health workers as a field standard. Everybody needs dedicated supervision time, not rolled into clinical supervision, but clear CHW, clinical teams reporting lines. So I don't know if everybody knows the difference between regular supervision and clinical supervision, but there is a distinct difference. And I highly recommend if you have community health workers to try and write into your proposal, your grant, time for them to have clinical supervision. It is a lot to hold on to. You're not a therapist, but you hold on to everybody's problem because that is what we do. We go out and we solve the issues and we make sure you're navigated so you can get the service you need. But that's a lot to hold on to because you're also hearing the story of each patient and you're also of sometimes, especially in the healthcare setting, you're the person who's relaying that information that the doctor doesn't know, that the other person doesn't know, but they give you that information because you have that availability to go out and be in the community with them. There's a sense of familiarity that sometimes comes with being a community health worker. Also, that's the same thing. I can say the same thing for peers or the same in the same vein for that. But community health workers, again, very structured and making sure that we're getting you to that next a service that you need. But a lot of times it comes with those stories and that's heavy to hold. So we want to make sure that people are able to have a source for reference. So with your regular supervisor, making sure that you are able to have that quality supervision with them so that you make sure that you're checking off your paperwork, that you're doing, you're providing quality referrals as well. There's no new trends that you're looking for. It's very important to be thinking about that. We may start seeing patients doing something that's very different from how they normally are. Or in the case of HIV, you may start seeing them saying, oh, no, it's not IDU that they're doing. They're having riskier practices because of X, Y, and Z. Being able to relay that information while talking to your supervisor helps them to map the story and also look at new avenues and services that may fit the community now. So having that supervision is really great on the program side as a whole, but also individually making sure that you have the necessary tools, equipment, the safety, and that life happens, that you feel supported in the work that you're doing. The other part, clinical supervision, is where you go to unload some of those heavy things, those stories that you have that that is staying with you. Again, as we talked about the promoters model, a lot of people come from the community, they speak the community, they do this. I remember in doing previous years, being a community health worker and being a Black man was there was a lot that came with it. There was a lot of luggage with it. And having to sort that out individually was really hard. And my supervisor was able to give me that ability to go seek clinical supervision, which ended up being, you get to go see your therapist and it's 1 hour once every 2 weeks. And it's easy remedy to that. The second thing is making sure you have a workflow integrated throughout. Nothing slows down, community health workers more than that referral trigger. Being referred to the community health workers, making sure the community health workers get that referral, and then B, having an effective way to track all the referrals that are going out from the community health worker as well. So that's whether it's physically or virtually, making sure that there is dedicated protocols in place for handing off these referrals. Um, our clinical teams forget. And before long, as things are just sitting there, you start to think, is this real? Am I actually doing something? And you are doing something. It's just there was not a workflow in place to support all the referrals that you're sending out. Sometimes that looks like a EHR or an electronic health worker where you're documenting things. And sometimes it's other web-based services like Aunt Bertha that you can go in and put a referral to this place. And then the other one is, well, if this is a service that's in-house in the clinic, I need to take you by hand and walk you down there to this place, get you help signed in and enroll. Sometimes that is the role as well. But having a good workflow and making sure that it is a live and living workflow is very integral to this. And when I say live, I mean being able to be malleable and mendable throughout the program, because nothing slows us down more than not being flexible in how we are working our system. People change, the program has to change with the people. Match your community as much as possible. The third one is the funding and sustainability. As I've said over and over again, you have to layer sustainability into this. When the grant ends, the program ends, and all those wonderful services and systems that you put in place go away as well when that program ends. It's heartbreaking, but it is something that we see over and over again. I've seen a lot of CHW programs that were research focused, and like we talked about earlier, but when that research ends, you have this position that's done wonderful work, but no infrastructure to sustain that wonderful work. And also the institutional memory. Whatever was great about that program, when these people leave, it leaves with them unless you've already set up some type of institutional memory to support that. So sustainability is not just funding, but it's also, does the program have everything it needs set up to have institutional memory? Can you come back to it if you have a new employee? When they come in, will they have something in front of them that they can read and understand exactly what your program's intent, purpose, and the delivery of those deliverables are? And the last thing is that data and accountability. We know we have reporting for grants. Sometimes it's a little bit simpler because it's towards the end of the grant cycle. You do one big report. But if you are looking at sustainability, if you're looking at doing anything around fundraising or you're doing some work with your development department, it is important that you are capturing data correctly. If you are exploring the long-term solution with Medicaid, Medicaid has its own list of things that you need to have in place to say that you've done this work, and it needs to be captured in a way that fits and suits your direct service staff, but also Medicaid. The program that survives are the ones that can show their work, and that is the baseline of this. So we're going to talk about dashboards as well in session 4. That's something there, but I loved when I was a community health worker, I developed my own dashboard, and it just kept me organized on my goals and my objective from that grant, but also the other things that I was like, if we could have this service, if we can have this thing right here, or if we are capturing this information correctly, maybe I have something substantial that it may not fully fit this other grant in this other uh, department, but we can feed off of it because we have the data to support the outcomes of this. All right, next slide.
Yeah, so we're going to talk a little bit more about the housing aspect of CHW work. And this is really one of this curriculum's core framing pieces is housing is health, right? And so per the February planning meeting a while back, housing, the stance now that HRSA, BIPIC, and HUD are taking is that housing must be positioned as a life-saving prevention and also as a responsive service. And that is their stance, that is their framework, that is how they are talking about housing and health and that intersection. Some examples, permanent supportive housing, which I think Lawrence, you mentioned this a little bit earlier today. But that intervention of supportive housing reduces emergency room use by 24%. It reduces inpatient days by 29%, and it reduces Medicaid costs by 50% among individuals experiencing chronic homelessness who are also high utilizers of our emergency health systems. And just putting it plainly, right? Without housing, without somewhere to go and keep your things organized, without somewhere to go and rest after maybe a medical intervention, without some creature comforts, it's difficult to adhere to things like a medication schedule, to complete follow-up visits when maybe you don't have an address that's consistent or a phone that's consistently on. It also makes it more difficult to maintain healthy hygiene protocols. And so all of these aspects that we think of when we think about health and wellness are are based on the fact that this person has a place to actually engage in all of those things. It is based on the idea that this person is housed in a place and is able to interact with different things, has the ability or at least the environment to be able to manage their medication and to have healthy hygiene, so on and so forth. And so screening for housing stability is in itself a prevention service that creates the foundation for all of these on the screen and others not listed, but any other clinical intervention needed.
Where are you going to lay your head at the end of the night? That
Exactly.
huge piece. And if you can't, we've done this several times, but if my client can't lay their head down at night, or if they're so worried about that, they're not going to take their HIV medicine, they're not going to take their mental health medicine, they don't care about it. Half the time, if they can't, the first thing they're thinking about is food after housing, and where they're going to stay.
Mhm.
So if you don't have those things in place, then we're missing a huge component, that is life-saving, for our clients.
1,000%. Things like picking up your refills or even paying for your refills, things like keeping your medicine in one spot and you know that it's there and every day you go to that one spot. Those kind of consistencies are nearly impossible, or I wouldn't even say nearly, they're impossible to realize without some stable place to stay.
Yes, everybody deserves at least
Mm-hmm.
have a baseline of Maslow hierarchy needs satisfied. Absolutely. Housing,
Mm-hmm.
and this is so important when we get into chronic disease, more specifically, having a place where you know that is safe for your diabetes medicine, or that is refrigerated if it needs to be refrigerated. Safe place where you don't feel targeted or discriminated against with your HIV medication or your mental health medications. Those are very important, to not feel scared about who you are and your
Mm-hmm.
basic identities, because you have infrastructure in place that supports who you are.
Absolutely. Okay, so we have a little bit of a scenario, and maybe we can, let me see more of you on my screen at one time so I can see what interaction we're getting. But so the scenario you're seeing on the screen is drawn directly from field experience across multiple CSH engagements. We work nationally, and this is something that's come up a lot. And the scenario is a community health center launches a CHW program to improve diabetes management. Initial home visits reveal that 40% of enrolled patients lack stable housing. CHWs report that medication adherence counseling has limited impacts when patients have no refrigeration for insulin or a consistent space for meal preparation. Is this something that sounds familiar to you all? And you can give me a reaction or raise your hand or put in the chat. I'm seeing a big nod from Debbie, an emphatic nod. Okay, yes. Okay, so this is something that's familiar, right? That is what we were thinking as well. We've heard it all over the place, and thank you for your reactions. Okay, that is confirming. So the health center pivots in this scenario, and CHWs are trained to screen for housing instability first, and then to connect patients to local rapid rehousing programs before initiating any chronic disease protocols. The question that we have for you all is how would this shift your program's workflow? Is this a significant shift where you feel like you have to rethink, your workflow A, B, C, D, E, F, G? Is this something that feels like you could implement it into your workflow Maybe there's a couple meetings about it to make sure everyone's on board, but it doesn't feel like it's really impacting your model too much. How would that change impact how you all work right now? And feel free to come off mute or in the chat, whatever you're comfortable with.
And I guess a baseline question, do you all use a housing first principle in your current program? No?
Does anybody currently do this? Does anybody in your role right now, you or staff that you work with that are CHWs, do any type of housing screening?
So Rochelle said we have homeless programs that with patients that have many issues like this and refer them where they use housing first.
Okay. Our goal is to do a prepare screen or review that screening with all interactions, regardless of referral reason, so that we can get the full picture of patient needs. If housing instability is listed on prepare, we then complete housing assessments and connect them with the housing coordinator. Okay, so this is familiar to some of the folks in the room. You're already doing this in your day-to-day jobs. And for others, and you don't have to, come off mute or be in the chat, but something to think about is what would this kind of change look like in your day-to-day operations? Is it feasible? What training would be needed for staff? Just what are the logistics of starting down this path of screening for housing for the folks that you come across? So,
And
oh, Lawrence, go ahead.
I was just going to say, we know that when you're doing screening or taking on housing, housing is a huge thing. And with housing, you don't want to promise things that you can't deliver on, as well as you want to make sure that you start off with resources that are there. But like we were saying earlier, there are resources that are there that hopefully from here you can have some connections with and building out and improving programs through partnerships and embedding as one of the other models talk through, just so you have these resources with housing, with transportation, with food security.
Mhm. Yeah, thank you. I think what time is it? 21? Okay. Just a couple slides left. Wanted to highlight some pitfalls, some common pitfalls in CHW program design. There are 4 listed here, and these 4 are responsible for ending 90% of CHW programs within 3 years, which is a very, very high percentage. And each of these pitfalls is preventable, right? And the first is role ambiguity. I know we talked about this a little bit earlier. And Lawrence explained the C3 framework. And the C3 framework really solves for this. Looking at your job descriptions before they go out, aligning it with that C3 framework, making sure as people are coming in, we're assessing them against the C3 framework, and we're assessing the position against that framework as well. The second pitfall is the supervision gap, and Lawrence talked a little bit about this too. But when a CHW is supervised by someone who either doesn't have CHW experience, has very limited time, or both, and that is very common in supervisors. I know when I was in direct service, it was difficult to grab my supervisor when I needed some of that time because this is the person who's super busy doing a million other things, just like I am. The fix for this pitfall is dedicated supervision blocks, and they have to be carved out on a weekly basis, a minimum of 2 hours a week, likely higher depending on how many CHWs you want that you're supervising. And making sure that your supervisors in this position do have some CHW experience. Like Lawrence mentioned, supervision and clinical supervision are very, very different things. The third pitfall is single source funding. And so that's kind of where that grant conversation came in earlier, when a whole program is funded by one grant or one source. And then you get to the end of that grant and it's a big question mark. Does the program end? Do we have some other funding source that we can tap into? But it's a stressful situation to be relying on one source of funding. And the fix is to, of course, diversify funding sources from day one and then to focus on sustainability, like Lawrence mentioned. And he also mentioned that there are 29 states that now have some Medicaid reimbursement pathways, which can supplement under other funding sources. We know that not every state has this option right now. We're hoping that that comes in the future. But if you are in one of those 29 states, and you're, at the level of kind of programmatic design or responsible for financial well-being and sustainability, it is definitely a path to explore. It is a door to open. Medicaid is notoriously complicated, but people are doing it. People are using it, people are billing for it, and people are getting reimbursed. So it absolutely is doable. And then the last pitfall is burnout. So unreasonable caseloads, vicarious trauma. These are all very, very common in the CHW position. Per guidance from the Penn Impact Operations Manual, caseload should be capped at 40 to 60 per CHW. However, that also depends on acuity, right? If you're seeing a lot of individuals who have a very high acuity, 40 is going to be a really, really, really overwhelming caseload. So we have to balance acuity with also what seems right for a manageable caseload so we're not burning our staff out. And then, Lawrence, I will pass it to you to wrap us up.
Absolutely. So there are 6 domains. We really want you all, and as Maya said earlier, you'll get the link for the workbook, but we really want you all to think about your program readiness, whether you've been doing this a long time or you haven't. There may be some components that still may be loose that we can tie up during this session. So this readiness assessment looks at 6 domains that you all can run this week with your group. And I also want you all to think about it while we're here now. You may have already done similar assessments to this, but be thinking about this as we're going, and we'll have a brief conversation about it, and then we'll wrap it up. But some of those domains, you want to have leadership support. Is there that one person that is an executive sponsor, a specific person who has real authority over budget and staffing, not leadership in supportive way, but a name that you can say this, the doctor who's over your department supports this. That's someone who has real power, typically, if they're the head doctor for that. That's something to think about. That's something that you can do. And if you can't say someone's name right now, when you look into the workbook, you will score it low. The scores are between 1 to 5, but for this one, if you can't name that person, you want to score it low. But that's something to really have. You need a champion for your program to be effective. The second one is funding. Do you at least have 2 identified funding streams and at least 18 months of runway or funding that you have right now? A single source is a single point, and it can lead to failure and loss of services and loss of something very essential to your community. 18 months is what gives you time to fix problems instead of just surviving them. We get into this surviving mode a lot of time, especially with our chronic disease programs, and you really want to think beyond that. And again, having that leadership support from that doctor to the board member to even the CEO to know that this is all working effectively, or the COO. You want to make sure that that you have a graded funding stream. Not saying get rid of the grant, but I'm saying support the grant. And you'll also see when you're doing that and you're having multiple funding streams, what you can do with that other money from the grant, where it's incentives or safety gear for your direct service staff, their cell phone, making sure that if they are in their car, a lot of times that they have a quality insurance that they can use, so that if there is a car wreck, something's happening with they're transporting a patient, which we do not recommend, but a lot of people do, just because of the realities of where our patients are, that you have some type of insurance to support that person and that your organization is not liable. The third thing is staffing. Is your supervision structure actually on paper? Do you have enough people to meet the need of the clients? Do you have enough representation of the staff that of the community on your staff? Do they have all the knowledge that they need? That brings us to the next one, which is the training. Is there a defined onboarding plan and ongoing training? we are not the one thing that in life that is constant is change, and change means that everything is up in the air, whether it's funding, whether it's knowledge, whether it's the safety of the community. Maybe there's a new, and this is extreme, but I've seen it happen here in Boston where there's a new community that's formed themselves in the form of a gang that's here, and it's more complicated to travel and go through this area because of a particular way. So you want to make sure that you have some training and also connections to local street outreach teams, so you have some understanding of how to navigate the community more effectively if you don't know already. But that's something that's constant training. Another one is making sure people are Narcan trained, making sure they have some CPR. Hands-on with CPR is also effective as doing mouth CPR, but a CPR certification could be something that you can pay for your staff if you have more money in your grants. So going back to that funding stream and braiding that additional dollar amount, training is so important to this work. It gives your direct service staff continuous education, but also a sense that they're being seen because you're investing in their education, you're investing in them exploring and expanding and their knowledge, as well as exploring and expanding the program that you're working on. That the most, I will say this till the end of time, my old supervisor, I would work for her forever if we could, because she invested in me so much that I returned that investment to what I was doing with my patients. I was dedicated to my organization because I was invested in myself. Um, so the other thing is workflow. Are your referrals triggered and triggers effective? Are the warm handoff program protocols documented and endorsed by your clinical team? That's really important. Are you having those clinical what we call soups or supervision time when you're doing a round table around the clients that you're sharing? Those are important. It gets that information that again that we talked about that may not be shared, documented, so we so everybody on the team knows how to more effectively serve the patient that we're talking about. Both
Really
world,
quickly,
yes,
Lauren, not to interrupt, I'm so sorry. Really quickly, I just wanted to announce to the group, I know it's the end of the hour. There's a survey that's going to show up on your screen. I think it's like 20 seconds worth of your time. If you don't mind just filling that out before you hop off today. And Lawrence, please continue. Sorry for that.
and I'm almost done. The last one is a data system. And data could be your EHR or CRM, which is customer relations management system, or paper, but just having a way to track and refer back to so that funding is aligned, especially if you're exploring other services, funding streams like Medicaid, you really, really, really want to make sure that documentation is number one. You can trace the story back through documentation. If something comes in with a client complaint, documentation helps support what happened, who did it, who was responsible for the outcome, and how do we modify that or fix the issue? Is there a fixable issue at that? So those are 6 domains that I want you all to go back through when you get the workbook and just rate yourself. Where are we right now as our in our program? Even if you're a pilot or you've been doing this, where are we in our program? And we'll come back and we'll talk about that more in our next session. Next slide, please. All right, some key takeaways. Number one, a community health worker is not a navigator. They're not a peer specialist. The 3 roles are distinct and there are 3 different scopes. They can overlap. A person can be someone trained as a navigator, trained as a peer, but serve as a community health worker. They're not mutually exclusive. We're just saying for funding and for documentation, making sure you have clear boundaries is really important. Number 2, housing is clinical infrastructure. Screen for it first if you can. Without it, every other intervention can be compromised because they don't have adequate places to store things or they don't have places to go afterwards. I've seen clients that once they leave my office, they're sitting outside because they have nowhere to go or they're waiting for the shelter to open up at a certain time so they can get on the list. But that is something really critical to know so that you can help service your clients better. Number 3, match your model to the patient community, impact for chronic, path hub for billing, sorry, promoters for community alignment, pick one, don't graft it, but pick it and then start making sure that you specialize it for your community. Everything, I know we said earlier, don't mix and match, but everything is malleable when you're having a community health worker program. It's going to shift, it's going to change, and that's the only thing that's constant. And being ready for that flexibility is really
Yes.
important.
Yeah, yeah.
Number 4 is design for sustainability on day one. Funding, funding, funding. Think about how important and impactful this is. Not today, but 3 to 5 years from now. What does that look like? What does this program grow into as well? You covering maybe just one disease, or you're just doing this for housing. But once everybody sees how effective this is, everybody's going to want a community health worker to help on their team. So how do we further spread that across the health center? Number 5 is data line. As we know, that's where the story lies. When you go back to your funders, your ROI, that is the most important thing. When you put it in the media, you let them know what you all have done. That paperwork, that documentation, that is where you where that lives. But also, more importantly, if anything's coming up, documentation is where we make sure that our clients are serviced at the highest capacity. Just really quickly, and I'll give it 30 more seconds. If these are any of these are extremely out there for you all, or something that you haven't thought about, just put it in the chat and we'll make sure we'll explore one of these zones from the key takeaways in a later session as well, a little bit more in depth on how you can further enhance this particular domain at your organization. Next slide. So here's a list, and you'll get this in the slides of the resources that we did today. Let's go to the next one as well. Okay, really important is that you all know tomorrow is our next session. It will be at the same time. The cadence will also follow next week, next Wednesday and Thursday as well. Same time, 4:30 to 6. The next session is around the 6 domains of community health worker program readiness, self-assessment with your team. So bring your scoring there. The needs assessment is also going to be explored. And we're going to be identifying spaces that you all should look at more intentionally as you grow your program out. And with that, I just want to say thank you all. I know that this is a rather short one, but the next one should be about an hour to an hour and a half, depending on where we are and where we're engaged. If you all need any support, please don't hesitate to email us back from the email, and we'll make sure we can get you all some of the resources from today that we have. Maya, I don't know if you want to.
No, I just want to say thank you so much. I'm seeing a question in the chat about CEUs. I am not sure. Lawrence, are you sure about that question? Are CEUs available?
No, I don't think CEUs are
Okay.
available for this training, but we do in our training system center. I think we do have CEUs. Thank you so much for adding that.
Yeah, well, thank you all, and we will see you tomorrow.
Have a wonderful day.